Thank you, Michael, for this introduction. I couldn't understand, I'm sorry. I don't speak any Russian. I cannot even welcome you in Russian. But I'm very happy to be here. I'm very grateful to Michael and Anna to host us and to show us this beautiful hospital and to explain us your efforts in the care of patients with immunodeficiency and needing transplantation and patients at the border of hematology, oncology, and immunodeficiency, an area which is getting more and more important in my view. So Michael and I initiated a collaboration some time ago, and we got funding finally. I think he mentioned it, that it took us some time. But I'm really looking forward to increasing collaboration and to exchange people that can then pursue some common scientific interests. So today we have prepared 3 talks to make you familiar with some of the research areas that we are dealing with. We try to set up the talks mostly clinical, so it will be better for you to follow. But there are some research issues, of course, and we will point them out. Let me start by introducing you a little bit to the setting of Freiburg, of the Center for Chronic Immunodeficiency, where I come from, and introduce you into the work that we are doing. So, the Center for Chronic Immunodeficiency in Freiburg was founded 8 years ago, and it was our vision to integrate all expertise that we had around the area of immunodeficiency. That means immunology, hematology, transplantation, infectious diseases, both in pediatrics and in adult medicine, diagnostics, pathology, genetics, and basic science in one structurally independent institution. I think this was quite an innovative undertaking. It was supported by a large government fund, but it allowed us to really set up what we call an integrated research and treatment center. So from the zebrafish and the mouse model to the clinical application, the clinical study in one disease area. And I think this framework has allowed us to address some topics that wouldn't have been possible to address otherwise. And so our goal, our vision is to really understand immunodeficiency in order to be able to diagnose it and to treat it. So let me just briefly introduce you into the concept of immunodeficiency that was, the major understanding of this group of diseases for many years. The traditional view of immunodeficiency is that it is characterized by a lack of immune cells and immune mediators, which leads to a lack in antimicrobial defense, and as a consequence to infections. So the mainstay of treatment for these diseases is to replace missing cells or mediators by transplantation, for example, and to treat infectious diseases. I think it is important to understand that these definitions do not hold true anymore. So nowadays, I think we understand immunodeficiencies as genetic diseases affecting the development, effector function, and regulation of the immune system, which leads to symptoms that do not only encompass lack of antimicrobial defense, but equally important, lead to the lack of immune regulation. So the consequence of that is not only infections, but it's also autoimmunity, it's inflammation, inflammatory disease, and in part malignancies. And this conceptual change also has an influence on our therapies that we provide. So from replacing missing cells and mediators, we are moving on to gene therapy, to targeted cell therapies, and also to molecular interventions where we block certain signaling pathways in order to treat patients with immunodeficiency. And of course, it is an important challenge that we do not treat only patients with infections, but also patients with autoimmunity inflammation that need immunomodulatory, immunosuppressive drugs, and to find the right balance in patients with an impaired immune system to suppress the immune system is an obvious challenge. So what do we do in the Pediatric Immunology group? My personal interests from my training are T cells, basically. And from a clinical viewpoint, T cell immunodeficiencies, and I pick mostly those deficiencies where the aspect of immune dysregulation is an important one. So the first group of patients we look at are patients with combined immunodeficiencies. And we focus more on the less severe cases, so not patients with absent T cells, but patients with a partial T cell immune system that is not functioning properly. And in these patients, from a cell biological view, we are interested in T cell development and in T cell activation. The second group of diseases are patients with hemophagocytic lymphohistiocytosis, which is a dramatic hyperinflammatory disease that you are probably well aware of because of the work of Michael and others. And in these patients, we study T cell effector function, T cell cytotoxicity. And there's a third group of patients, which are patients with autoimmunity and lymphoproliferative manifestations, so big spleens, big lymph nodes, and various other aspects of immunodeficiency. This is a large and expanding group of immunodeficiencies, and from these patients we learn a lot about T cell differentiation, T cell homeostasis, and T cell apoptosis. So this is the framework of diseases that we're working with, and I want to introduce you to the first field, which is HLH, with a patient story. So this is a 9-month-old boy with fever who presents with fever up to 40 degrees for 5 days. He has been to his pediatrician with no clear infectious focus. He received antibiotic therapy without effect. He was admitted with hepatosplenomegaly for suspected leukemia, and upon admission he was found to have this significant hepatosplenomegaly, cytopenia in all 3 lineages, markers of excessive inflammation, including ferritin, very high ferritin levels, signs of liver disease, and in the bone marrow features of hemophagocytosis. This patient died within 5 days despite all therapeutic efforts from multi-organ failure. The diagnosis, hemophagocytic syndrome, HLH, due to perforin deficiency. I present you a second patient, which is an 8-year-old girl with a history of Still's disease, fever and cytopenia. She developed Still's disease at the age of 3 years, and the disease was reasonably controlled with MTX, with methotrexate and steroids, and now presented with high fever and vomiting. She was admitted with hepatosplenomegaly and diagnosed with an acute EBV infection, and she showed the same laboratory and clinical features: hepatosplenomegaly, cytopenia in all 3 lineages, excessive inflammation, liver disease, and in her bone marrow features of hemophagocytosis. The diagnosis, secondary HLH, or macrophage activation syndrome, in a patient with a chronic autoimmune disease, probably triggered by EBV infection. So one of the issues of my talk will be whether these diseases, these 2 patients that look very similar in their clinical presentation, really have the same disease. So let's go one step back. What is HLH? HLH can be defined as a hyperinflammatory disease that is characterized by excessive activation and proliferation of T cells and macrophages. And the name, as frequently in clinical medicine, is very descriptive. So the hemophagocytic part of the name alludes to the activated macrophages that are engulfing blood cells. And the lymphohistiocytosis expresses that these patients have very active lymphocytes, T cells in particular, that secrete high amounts of cytokines, and they have activated macrophages or histiocytes that also contribute to this enormous cytokine storm that provokes the inflammatory manifestations of the disease. Clinically, or the disease is defined clinically, so there's no definite diagnostic test, but it's a panel of symptoms and manifestations that defines the disease. And these are fever, splenomegaly, cytopenias, hypertriglyceridemia or hypofibrinogenemia, hemophagocytosis, ferritin elevation, soluble CD25, and reduced NK cytotoxicity. This definition was set up in the context of an HLH treatment trial some years ago, and you need to fulfill 5 of these 8 criteria to be given the diagnosis of HLH. Now, what are the causes for this disease? We know well that the disease can recur in families. It can develop as on the basis of a genetic disease. If this is the case, we call this disease primary HLH. And genetic diseases predisposing to this primary HLH are genetic disorders of cytotoxicity or some genetic diseases which are associated with an impaired control of EBV infection. Now you can see in this cartoon some of the molecular causes of the disease. This is a target cell, in this case an antigen-presenting cell. This is a cytotoxic T cell or NK cell. And upon interaction between these two cells, the T cells can mobilize lytic granules that are filled with a toxic molecule perforin and move these small lysosomal organelles to the site of contact, release their contents, and then kill the target cell. Now, if a cell is lacking perforin because of genetic deficiency, or it has a problem in the movement and the biogenesis of these organelles, and this is true in different genetic variants of HLH, of primary HLH, they cannot perform this lytic interaction. So this is primary HLH, but we know also that HLH can develop in the absence of a known genetic predisposition. And in this case, we call the disease secondary HLH. And a secondary HLH, by definition, requires some sort of a trigger. So it doesn't evolve autonomously, but viruses, in particular EBV, other infections, including Leishmania is an important trigger, lymphoma, metabolic disease, or autoimmune disease, are triggers of potent immune reactions that in the end lead to the clinical picture of HLH. So what's the link between cytotoxicity and the disease? Now, there are some important lessons from the mouse model. Perforin deficient mice, so mice that are genetically rendered deficient in perforin by knockout technology, do not develop HLH spontaneously. So you can let them sit in the cage until they die and they don't develop the disease. So the genetic predisposition to this disease appears not sufficient in this mouse model. However, if you infect these mice with a virus, this virus is called lymphocytic meningitis virus, and it is important that it's this virus and not another virus, because no other virus in the mouse is able to trigger the disease, apart maybe from murine cytomegalovirus. So only this particular virus, if you infect the mouse, will trigger the disease. And what does it do? It activates T cells. It's the most potent T cell activating virus that we know in the mouse. And these activated T cells, normally, when they are stimulated by antigen-presenting cells, in a negative feedback reaction, also kill these antigen-presenting cells. And this leads to a silencing of the immune response. It can settle down and come to a rest. However, if this feedback does not work, so if the T cells cannot kill the APCs, and they cannot kill virus-infected targets, this immune reaction is not interrupted, and T cells secrete massive amounts of cytokines, including gamma interferon, which is one of the major macrophage activating factors. And these activated macrophages, in combination with the T cells, then cause the disease phenotype. So that's a relatively simple scheme, and in the mouse model it works quite well. So if you take out the T cells by T cell depletion, the mice will not develop the disease. If you block gamma interferon, the mice will not develop the disease. And so these two factors are that's the critical axis of pathogenesis. And in the mouse model, of course, you need this trigger. So we don't really know at the moment whether this concept really applies to humans. And I think it's important to ask that critically, because obviously our treatment strategies depends on understanding the pathophysiology. So what we tried in a very simple observational approach is really to understand better whether this cycle of pathogenesis is true for human patients. So the first question is if T cells are really so important. So if yes, they should be highly activated in HLH. So we looked at simple markers of T cell activation in patients with primary HLH, in patients with secondary HLH that was triggered by a viral infection, and in patients with secondary HLH that had other triggers. And we also had a look at the development of HLH in patients with primary immunodeficiencies. These are rare patients, but they have been described. So patients with an HLH phenotype that do not have a cytotoxicity effect, but another genetic deficiency of the immune system. Okay, so these are a few data from the T cell analysis, and you can see here CD3 T cells. CD8, yes, this is on the x-axis is CD8, on the y-axis is HLA-DR as a MHC class 2 as an activation marker, and this is a normal control with a few activated T cells, and this is a patient with HLH where you can see significant HLA-DR expression on CD8 T cells, but also on CD4 T cells. And for this analysis, we just performed this simple stain in a cohort of about 100 patients. All of them had the full picture of HLH, at least 5 out of 8 criteria. None of them were treated, or some had received a bit of steroids and IVIG, and we excluded all patients with malignancy. And this is what we found. So this is HLA-DR expression, and these are the 3 groups. So patients that have the full picture of HLH, but no virus infection can be documented, and no genetic underlying disease can be found, is this group. And you see that there's significant T cell activation, but it's much less than what we observe in patients that have secondary HLH on the basis of a viral infection, or patients with a primary HLH. So these 2 groups, primary HLH or secondary HLH with virus infection, look very similar in their T cell activation profile. If you look at CD4 T cells, there's a difference. So CD4 activation appears to be most prominent in the patients with primary HLH. Another way to look at this is T cell differentiation status, and here we look at CCR7 and CD45RA expression, and the expression of both of these markers identifies naive T cells, naive CD8 T cells, and the progressive loss of these expression of these molecules defines here an effector memory population which is associated which is prominent in patients that have a viral infection, for example. Now, because T cell activation is also T cell differentiation is dependent on age, for this part of the study we only included patients that were younger than 1 year of age. Again, only patients with at least 5 out of 8 HLH criteria. And this is what we found. This is T cell differentiation in a normal individual. In black, you find the effector memory cells, and the white ones are the naive cells. So patients without HLH, of course, they have very little T cell activation. These are patients with a mutation in an HLH-causing gene, but no disease symptoms. So siblings, for example, that were identified as newborns. And you can see that also here, the T cells are quiet. And interestingly, also in the secondary HLH patients that did not have a viral infection, no significant T cell activation. In contrast, if you have a viral infection in the context of your HLH, T cells are dramatically activated. And this is also true for the patients with primary HLH. So the consequence from this is, yes, of course, we see a lot of T cell activation in this syndrome, but you can have the full clinical picture of HLH without any significant T cell activation, even in the first year of life. in these cases where not a virus or a genetic alteration is present. So look from the other way. We looked at the presence of HLH in primary immunodeficiencies, and in a great international collaborations, we identified 46 patients with genetic diseases not related to cytotoxicity defect who had developed HLH. And we identified 14 SCID patients with a variety of genetic diagnoses, 11 patients with significant T-cell deficiency, 11 patients with CGD, and a few other patients with other PIDs. And I think, 27 of these patients actually had HLH as the initial clinical manifestations of the underlying immunodeficiency. So SCID patients that presented as a first illness with an HLH episode, and 17 patients developed the HLH only after the PID diagnosis had already been established. Most of them had infectious triggers. So this, I think, teaches us, and we looked a bit closer at these T-cell deficiencies, and you can see that most of them had none or next to no T-cells. That the clinical picture of HLH with all symptoms in an infant can occur in patients that do not have any T-cells. So, suggesting that for the syndrome of HLH, you do not need T-cells. It's not a requirement, and I think the consequence of this is that, well, we will come to that in a minute. So just to sum up, so the full clinical picture of HLH can develop without significant signs of T-cell activation. It can develop in patients without T-cells and also without NK cells, because there were some gamma chain SCIDs in this group. And so the T-cell activation is most prominent in patients with secondary HLH induced by a viral infection, and in primary HLH, even if we do not have an obvious trigger. So the next question in this context to us was, we have seen a lot of patients with primary HLH where our conventional search for triggers was negative. So no virus identified, no bacterial infection identified. So we asked, does primary HLH really have to be triggered? And for that, maybe we did not look carefully enough. So we went back to material that we had stored from these HLH patients, and this was granulocyte pellets that we routinely store for analysis. And as a proof of principle, we analyzed patients with virus-triggered secondary HLH. We used this material and did targeted PCR for a panel of 20 viruses. In this material, we were able to find all the triggers that were reported from the clinical side. In one patient, we found CMV that had not been found in the clinical setting. So suggesting that in principle, this method is able to retrieve viruses from this kind of material. And then we went back to our cohort of HLH patients with perforin deficiency, MUNC deficiency, MUNC 18 deficiency. A lot of patients where never any trigger was found. And you can see their age range and their soluble CD25 receptor as a marker for the activity of their disease. Most of them received aggressive therapy. And you can see that looking at all of these different viruses, we did not find much. There were 2 patients with positive CMV PCRs. So all of them were clinically reported to have no viruses, but because they were sent from outside, we repeated all this analysis. No viruses found. And here we have 2 unusual viruses, TORC10 TORC10 which are where it's not clear whether they cause disease at all. So you can find them in normal newborns without any clinical symptoms. So suggesting that, in fact, I don't think we have missed many of the known viruses. And what we are trying to do now is to go back to the material and do some unbiased genetic amplification steps in order to see whether maybe there's an unknown pathogen, an unknown virus that we are missing. Because the immune response of HLH is so dramatic that it's hard to imagine that this should just start without any trigger. Okay, so from these studies and observations, I think there are two question marks into our pathogenetic scheme. We do not know at the moment whether for primary HLH you really need a trigger. I'm not really convinced that an exogenous trigger is needed to kick off the disease. And there are two, I think, aspects that may be relevant for this. The first is that it has been described that patients can manifest with CNS-only HLH, so no peripheral symptoms at all, no activation, but just a cerebral HLH. So also in these cases, no pathogens have been found. And also there's congenital HLH, so HLH can start in utero or within the first few days of life in patients with genetic mutations. And also in these cases, very rarely infectious triggers have been identified. So it could be that HLH is actually in genetically predisposed persons developing without an obvious infectious trigger. And I think this is important because it tells us from the immunological side that maybe perforin has a role in regulating immune responses even under resting conditions. And it's important for our treatment because fighting the trigger or targeting the trigger is one of the key elements of HLH therapy. The second implication is that you do not necessarily need T cells to get the clinical syndrome. And this means that our current criteria for looking at HLH, so these 5 out of 8 criteria, do not distinguish between a T cell mediated HLH and a T cell independent HLH. But this is very important for therapy because we are starting to think of ATG, CAMPATH, T cell directed therapies, and using them in the clinic to treat these patients. But if T cells are not playing a role in some of these forms, then the treatment hits the wrong target, endangering the patient. So based on these pathogenetic considerations, I think that the term HLH at the moment is not precise enough to define what is going on. And I would rather prefer, although I'm probably I'm criticized for this by others who think differently, I think what we see in the clinic, these 5 out of 8 criteria, is a hemophagocytic inflammatory syndrome. That's the umbrella term. That is what's happening, hemophagocytosis in the context of severe inflammation. And this end of the road can be triggered can be either dependent on lymphocytes, and this is the case in primary HLH, and it's true in secondary HLH that is triggered by infections. And then I think the term hemophagocytic lymphogistiocytosis is appropriate, and targeting T cells is an appropriate strategy. But then there's another form of the disease which is not dependent on lymphocytes, and I think for this the term macrophage activation syndrome, which is used in literature, particularly in rheumatology, is probably the better term because the macrophages and the cytokines are the target for treatment. And these includes autoimmunity triggered disease. It includes, well, leishmania is also a macrophage activation syndrome, but treatment is of course against the pathogen. Metabolic diseases, some infection-driven HLHs, and also the non-cytotoxic immunodeficiencies that lead to HLH. So 2 different routes of pathogenesis, and I think important terminology because you have to understand what you're treating before you choose your drugs. Okay, let's switch gears a little bit and come to diagnostics of the disease. Primary HLH needs a rapid and reliable diagnosis because of the need for stem cell transplantation. These patients, even if successfully treated, will all relapse unless they undergo stem cell transplantation. Now, as you have seen, there's genetic heterogeneity, so there are 6-7 genes that can be responsible for this primary HLH. And sequencing all of these genes is expensive, it's time-consuming, and also there's a limitation because even with all the genetics that we know today, it is not possible to establish a diagnosis in all patients where we have a clear indication of a genetic disease because of affected siblings, consanguinity, and impaired cytotoxicity. So the question is, what is the place of immunological screening before we go to genetics, and how can we reduce the need for sequencing in this setting? And the second question is, what is the role of the new technologies? What is the role of exome sequencing, for example, to reach a final diagnosis, which is important, maybe not so much in the acute phase of the disease, but then for the family. And I would like to briefly describe to you the setting for care of HLH patients that we have established in Germany. And the most important person here is Greta Janka, who you see here, who has pioneered this field in Germany and also has made important international contributions to raise awareness for this rare disease. And Kai Lehmberg is working in her team and has now taken over many of the tasks that Greta started. And with Kai is Udo zur Stadt, a geneticist who's helping us with that disease. Now, in Germany, every patient who has HLH is reported to the center in Hamburg. So they provide clinical information, they say, here's a new patient, and they get an immediate advice on diagnostic evaluation. And the diagnostic evaluation in terms of immunological tests is done in Freiburg. So they send a few milliliters of blood, and we, within 48 hours, can provide them with results from these assays. And this information is relayed both to the coordinating center in Hamburg, but also to the treating clinicians. And with these tests, within a short time, we can say, is it a genetic disease or is it not? And thereby direct the further proceeding. In parallel, if we find something in the immunological evaluation, a DNA is sent to Hamburg, and they are doing their genetic studies, either targeted sequencing for diagnostic purposes, and the results usually are available quite quickly now because of the pre-screening. And we put together all this information in video conferences that we have every 3 weeks, where we discuss all of these HLH patients and integrate the clinical, the genetic, and immunological information to give feedback to the clinicians. And this is working quite well. And of course, we have unsolved cases where we have a high suspicion that something is going on. And for these patients, and they are getting rarer now, we do further function studies, and we also do exome sequencing in collaboration with Hans Christian Hennies, usually on the basis of family trios. So what's the experience with this approach? Between 2010 and 2014, we had 405 patients that were referred for suspected HLH. Not all of them had the full clinical picture. Among them, 173 had really at least 5 out of 8 criteria. 113 had what we call incomplete or atypical HLH, so less than 5 out of 8 criteria, or CNS-only disease, maybe suspected HLH. 18 were asymptomatic, so these were siblings of affected children. And we had incomplete information on 101 to put them in clearly put them into one of these categories. Now, among these, we do perforin stains, ZAP and ZIAP stains. These are intracellular protein stainings to look for these deficiencies, and do a fresh NK cell degranulation assay. If this is normal, these two tests, we do no genetics. And this has reduced the workload for the genetics investigations. If this test is abnormal, we do a confirmational testing 48 hours later. So in addition to the fresh NK cell stimulation, we use pre-stimulated NK cells. If this is normal then, because this test can be abnormal in patients that in the end do not have a defect, this helps us to discriminate, and those that are normal, we only do genetics in selected cases. If abnormal, genetics is done. And genetics includes the targeted genetics, or if no mutation is found, the exome. So these are typical flow cytometry pictures for these patients. You can see that we had 29 patients that were abnormal in this protein screening. And this is what the stains looks like. This is CD56 versus perforin. And you can see these we have 15 patients with perforin deficiency, and none of these cases had normal perforin expression. 3 patients out of 15 had reduced but still detectable perforin expression. and 12 patients had completely absent peripheral. Now, these are patients that all have the full picture of HLH, so we did not include here any, among the peripheral patients, any other ones. Then the SAP staining. None of the patients with SAP deficiency in the end had normal staining. One had reduced but not absent staining, and 3 out of 4 had completely absent SAP staining. And this is the ZIAP. Again, none with normal staining, reduced staining in 1 patient out of these 10, and 9 patients had absent staining. So, in summary, with this technique, we can identify all patients with mutations in perforin, ZAP, and ZIAP. And this is, in parallel, we do the fresh NK cell degranulation assay. In this test, you stimulate or incubate your NK cells either with medium. In this case, they do not express any CD107. Or you stimulate them with an NK-sensitive target cells, which provokes the expression of the CD107 surface marker. And if you have a genetic disease that impairs degranulation, like MUNC13 deficiency in this case, this response is completely absent. Now, for the ambiguous cases, we have this PHA IL-2 stimulation assay, because using this pre-stimulation, you can increase your response. But here, if you have the defect, this does not work. So, among 173 patients with full picture of HLH, we had normal NK cell degranulation and did no genetics in 100 patients, saving significant costs. And in the patients with abnormal fresh NK cell degranulation, you see here the results. 10% is our lower cutoff of normal, and these are 74 patients with low NK cell degranulation. If you take those with less than 5% degranulation, you can see that most of these patients also have an abnormal PHA response, and here you find most of the genetic cases. These are the primary HLH cases. Patients with abnormal primary and normal secondary do not have mutations. There was one single patient with the Chidiakigashi syndrome without albinism, a very unusual case that was identified here. And among these patients with 5 to 10%, there are a few, but not very many that in the end have genetic disease. And these can be found by the abnormal stimulation assay. So, okay, so let's skip this. So using this algorithm, we can identify patients quite quickly and go to targeted sequencing. But there are some that have functional abnormalities, and you can see that here. This is the CD107 response, and there are still a significant number of patients where all known genes have been sequenced, but no mutation has been found by Sanger sequencing. So here we do exome sequencing, and we've done this in this cohort for 8 patients. For 14 patients, we have not done it because there were clear other explanations like lymphoma or metabolic disease. In some patients, there was no material left. In some patients, there was a longer follow-up period historically with no relapse. So we focused on these numbered patients, and this is what we found. The first one, well, Sanger sequencing is also not perfect. He had a complicated inversion of his gene, so the sequence was normal, this inversion was only picked up in the exome analysis. In another patient, we had a RAP27A mutation, and we did not check for this gene because the patient had no albinism. It is now clear that albinism is not, in all of these diseases, is not a necessary prerequisite because there are protein domains and mutations that restrict the phenotype to a hematological phenotype without the albinism. So it must be included in the genetic analysis. We found one new gene, AP3 delta 1, and I'm not going deep into it, but it's causing a new type of Hermansky-Pudlak syndrome. This was an albinism patient with what we now call Hermansky-Pudlak syndrome type 10. It's a disease that is similar to Hermansky-Pudlak syndrome type 2, which is a known disease associated occasionally with HLH. But the difference is that these patients with type 10 have a severe neurological disease. And then, as you can see, this method is not perfect, so in many patients we have no obvious candidate genes, despite the whole exome analysis. In one patient we detected Wolman disease, which is a genetic disorder of lipid metabolism that has been associated previously with an HLH phenotype. Okay, to conclude, I just want to show you from these 4 years our distribution of genetic diseases in Germany, and I think in Russia as well. FHL3 is the most frequent genetic disorder. So the majority of patients had FHL3. FHL2 and FHL5 are second. FHL4 is a rare disease in our cohort of patients. These are the albinism syndromes, which are not so rare. And here we have the 2 XLP variants with 5 XLP1 and 10 XLP2 patients. This compares to a previous or recent publication from the Italian group, who analyzed a 16-year period with 171 patients. And they have really a completely different group. So FHL2, perforin, is their most frequent disease, followed by month 13. And the other diseases are rarer than in our case. So I think you have to look in your population, really, if you want to understand the prevalence of these different forms. So using our immunological screening, we think that we have not missed a patient with genetic disease so far. Screening has reduced our genetic investigations. Only a third of the patients with full HLH undergo sequencing. And we have increased the likelihood of detecting mutations, so 70% of the patients actually have the mutations. The whole exome sequencing uncovered unexpected phenotypes and 1 novel gene, but despite screening, pre-screening immunology, and then whole exome sequencing, we could not find a diagnosis in more than 50% of the patients. So this is now my, I don't know what's the time. I'm over time. Okay, well, then maybe I discuss that with you later. It's about registry, and I don't think we have to discuss it.
Shortly, just take your time, please.
Okay, good. So, just a brief note about therapy. What's happening at the moment? The standard of care in Germany and many other countries is etoposide-based therapy in some modification of the HLH 2004 protocol. There are several pilot trials going on. HIT-HLH or EuroHIT-HLH, which is a combination of ATG, which is given upfront, then followed by etoposide. The target of this trial is to recruit 60 patients. There are around 48 or so at the moment, and so the results will probably be available, hopefully, by the end of next year if this trial is continued. There's a trial using Campath, started in Paris with a target to recruit 30 patients, and this is the Campath only and first-line therapy, so no etoposide, no ATG, directly start with Campath. And the target is to recruit 30 patients. And there's an ongoing pilot trial with anti-gamma interferon, where a pilot study is in the process of being concluded, and this will be followed by a larger trial. Now, looking at this landscape, I think it's a bit difficult at the moment to decide what is the best treatment, and we all agree, I think, in the HLH community that it would be really important to have a randomized trial to find the best treatment. So the question is a randomized trial in such a rare disease feasible? And to find that out, a registry for HLH patients, an international registry, shall be implemented. And this is a joint project of ISIT and the Inborn Errors Working Party and the Histiocyte Society. And the idea behind this registry is really to collect data to judge the feasibility of a trial. So we want to have a slim registry, not so many details, but we want to find how many eligible patients per year would we have, what is their outcome associated with current standard of care, because also supportive care like rituximab, antifungal treatment, and all this has improved in the last 10 years. What is the frequency of CNS disease? What is the time to transplant for these patients? And what is the time from clinical manifestation to the first HLH-directed drug. The secondary goal of this registry is really to help internationally to improve the infrastructure for care of HLH patients in the countries. So we want to have a standardization of patient registration documentation, of diagnostic evaluation, and implement a better network of national and international collaboration. The database that we have chosen is the Marvin platform, which is used also in the Pediatric Immunology Oncology German group, and it will be a web-based registry. Inclusion criteria: all patients with at least 4 out of 8 diagnostic criteria and receiving HLH-directed therapy, or high suspicion of an isolated CNS HLH and receiving HLH-directed therapy, and all genetic cases, even if they are asymptomatic. We exclude patients with malignancies, rheumatology disease, metabolic disease, Leishmania infection, because we want to focus on primary or infection-only secondary HLH. And the patients will be registered within 3 months after treatment's initiation, and then there will be one follow-up registration 1 year later to retrospectively judge how the patient did. More than 20 countries will participate, and the registry will open in 2016, and I hope with your participation. So this is what I had to say on HLH at the moment. I would like to thank my research group. This is Sandra Ammann, who is doing much of the work at the interface between the diagnostic evaluation and study with human material. Wood Garter is doing mouse work in HLH, helped by Nadja Goos as a technician, and Ulla Bartos is helping Sandra as a technician. And of course, there are many external collaborators. I pointed out here 2 groups, the group in Hamburg and Gillian Griffiths and Sam Grieve in Oxford, in Cambridge, I'm sorry, who are helping us with some of the cell biological aspects. And the Inborn Errors Working Party and ESIT as societies who support our work with many physicians. And these are other people from the Freiburg University Hospital that help with some of the studies. Thank you very much.
What's your attitude towards anti-IL-6 or anti-IL-1 treatment in HLH?
Yes.
Becoming a very popular discussion topic nowadays.
Yes. Well, I think this is exactly where the differentiation between the different forms of HLH becomes important. Because for the primary HLH, for the genetically determined disease, and also for some of the virus-driven severe secondary forms of the disease, I don't think there's much room for these drugs. In our experience, we have not used them in a primary fashion, but in patients with uncontrolled primary HLH, despite etoposide, of course, sometimes you try everything. And we include anti-IL-1 and anti-IL-6, and we've never seen a convincing response. This is different for the other group of diseases, which is not lymphocyte-driven, which is macrophage-driven, I would say. So what I would rather call a macrophage activation syndrome. Here, anti-IL-1 can be a very important drug, and also anti-IL-6. So in patients with a prior rheumatological disease, in patients with some of the metabolic background, and also in some of the difficult to classify ones, it is definitely worth giving the drug. But I think in the complex situation of a lymphocyte-driven primary HLH, anti-IL-1 and anti-IL-6 do not do the trick, in our experience.
Stefan, over the years we've seen some cases where we discovered only heterozygous among 13 patients, and so we haven't had the opportunity to look for deep intronic mutations. And the question is whether, what do you see this kind of genetic background, and if you could comment also on the degenic inheritance?
Yes. Well, I know I'm a bit different from others maybe. I do not believe in monoallelic HLH. So I think, you know, in most of the cases that have a clear HLH phenotype and have only one mutation of one allele, it hasn't been looked hard enough to find the second one, in the introns and so in other areas. That's my opinion. It's not really, fully scientifically based. But I think the recent experience with these intronic mutations shows that this is, that some of these genetic lesions are really very hard to find. The other issue is, can you have a cumulative effect of heterozygous mutations in several genes? Also here, I still wait to see the full demonstration that actually these hidden mutations have been excluded and the clear link between mutation and cellular phenotype and disease is established. So, yeah.
Thank you, Stefan.